Okay, great. Hi there. Hi again. As Katrina said, my name is Miriam Rafferty, and I'm so excited to be here with the Bryant Grant Foundation community. So thank you for inviting me to share the work of a large group of individuals that was put together by the Parkinson's Foundation to develop exercise guidelines and competencies for exercise professionals who are working with people with Parkinson's disease. And next slide. I'm giving this presentation, and I want to disclose kind of the context of where I'm coming from. I am a physical therapist, and I think what we do as physical therapists with people with Parkinson's disease would not work nearly as well if we weren't working with exercise professionals in the community. I have been funded by the Parkinson's Foundation for work on this project, as well as some other projects related to their Parkinson's outcome project, some physical therapy faculty training programs, and some research projects as well. And I do have research funding from a number of organizations for Parkinson's related work. Next slide. Here are the learning objectives, and hopefully at the end of this talk, you will understand the role of the community exercise professionals in the treatment of people with Parkinson's disease. You'll understand the benefits of exercise, although many of you probably already do, and that's why you're here today. We will discuss the 4 recommended exercise domains for people with Parkinson's disease and how to prescribe that exercise based on the guidelines. And we will describe how the exercise competencies can improve the quality of community exercise delivery. Next slide. So we'll be beginning with kind of your role in the treatment of Parkinson's disease. Next slide. So I see the interdisciplinary care team for Parkinson's disease as having 4 distinct parts. There's the physician bubble, which are the neurologists, the primary care physicians, internal medicine physicians, geriatricians, and physiatrists, potentially, or physical medicine and rehabilitation doctors. But on average, people with Parkinson's might see these clinicians every 4 months if they're lucky, but many neurology clinics can also be every 6 months. It can be really hard, and they don't see those physicians very often. Then there's the traditional interprofessional care community. This is what our traditional rehabilitation approach tends to be episodic and restorative. So they don't see any of these professionals, PT, OT, speech, psychology, social work. They don't see them until they're having a problem. And then they might go once or twice or 3 times a week for a few weeks or a few months. And then the traditional approach is then not to see them again. And that creates problems because in those interims, they're out there in the community. So then on the bottom left, you see the licensed exercise professionals. This is generally physical therapists is what I'm thinking of. They are working with the interprofessional team, but they also might be prescribing exercise. But we, as a physical therapist, we cannot see them 2 or 3 times a week at most, for the rest of their life. So we might see them that frequent for a short period of time, or maybe we have a different delivery model where we're seeing them once a month or following them. But we are really relying on the bottom right-hand corner, non-licensed exercise professionals, community-based exercise professionals, anybody else, and this could even be just a family member or an exercise buddy who is working and helping the individual with Parkinson's disease. Next slide. So hopefully working together, those individuals will can tailor the exercise routine and can help motivate the person with Parkinson's to keep up their exercise, on a daily basis or weekly basis. And next slide. So the exercise professionals are generally not licensed healthcare providers, but they could be. But most of the time, these are community providers who should hold a credential from some exercise association. So this could be the American College of Sports Medicine or the American Council on Exercise, ACSM and ACE, respectively. These credentials indicate that that person has met an established criteria, they have knowledge, skills, and competencies or abilities related to exercise, but those knowledge, skills, and abilities are focused on healthy populations. They generally also have some knowledge more of cardiac risk factors because that is one of the most common risk factors. They have education on appropriate form for exercise to prevent somebody from having a joint or related injury, but they probably, at least at first, do not have specific Parkinson's education. And so one of the goals of creating these guidelines and competencies is to create a place for people to go to get, what is the gold standard Parkinson's related education that you should have if you're working regularly with people with Parkinson's. These exercise professionals are an integral part of the team. Next click. And they, and one more click. They frequently interact with the client more often than the healthcare team. So group exercise professionals, frequently it's once a week or sometimes 2 or 3 times a week. Personal trainers, it depends on what's set up, but they are so integral because you are our boots on the ground from a medical professional side that we're counting on you to let us know if something's not quite right or if you have seen a change in function. They also, as a part of the team, we also count on them to provide safe and effective exercise programs that adhere to best practice recommendations. So as a member of the healthcare team, we want to be able to tell to our patients, oh, if you go work with this exercise professional, or here's a list of 10 trainers in the area that have all been through this training, then we are confident that they're receiving Parkinson specific exercise as opposed to just seeing any trainer at a gym. Now, any trainer at a gym might be better than no exercise at all, but we really want to make sure that that trainer is safe and effective for Parkinson. Next slide. Oh, sorry, 2 more clicks. And then, so this is where the trainers come in. You heard Katrina give really nice quotes and testimonials as to the benefits of exercise, and you hear some people, there's the carrot and the stick. So in this image, we have a dinosaur instead of a stick, but it's kind of looming over people's head that they know that they should exercise, and they feel guilty if they don't exercise. So we know we have that to help people with motivation, but it's a lot more pleasant, one click. If they have a coach, a trainer, an exercise buddy, can you do one click, John? An exercise buddy, a class, or a family member who is helping to help pull that person along and motivate them to exercise. And that's something that our community-based exercise professionals are just so good at. As Katrina gave that good quote about how much more fun it is to exercise in the community with their friends and other people with Parkinson's as well. Those exercise buddies are very motivating as well. Next slide. So now I'm going to get into the meat of what are these exercise, what are the exercise benefits, and then I'll talk about the guidelines themselves. Next slide. So exercise is considered an adjuvant therapy for people with Parkinson's disease. The American Academy of Neurology has quality indicators that state that neurologists should recommend 150 minutes of at least moderate intensity aerobic exercise to people with Parkinson's disease. Now, this is difficult because every person is different. So whether or not, to what extent they can accomplish 150 minutes a week differs across individuals, and how they're going to accomplish that is going to differ across individuals, which is where we come into play on the community exercise side. Then in other countries in Europe, Canada, and the UK, there are clinical practice guidelines for physical therapy that recommend early intervention by physical therapists to address individually tailored exercise prescription and physical activity promotion. And these clinical practice guidelines are coming in the United States. The American Physical Therapy Association should be posting their clinical practice guidelines for public review within the next month. But as of right now, taking these information together, we do want people with Parkinson's to see physical therapists to help provide some extra individually tailored exercise prescription and recommendations. But just seeing a physical therapist once or twice early after diagnosis isn't going to help them accomplish all of their exercise goals. Next slide. The exercise research in Parkinson's disease is very strong. We know kind of from a wide variety of studies that aerobic exercise can reduce motor disease severity and can improve gait performance, quality of life, and aerobic capacity. We know that exercise is associated with additional benefits on non-motor symptoms, including mood and cognition. And then the more traditional benefits of exercise are very task specific. And task specific means that if you're practicing walking, your walking will get better. If you're practicing balance tasks, your balance will get better. If you're practicing strength tasks, your strength will get better. Range of motion and mobility. So all of these things get better with practice, and exercise is something that you can do high repetitions and intensely to help make those benefits. Next slide. So where does some of this research come from? We have the standard randomized controlled trials that were discussed on the prior slide, but the problem with those trials is that the people who sign up for those exercise trials are really they're very motivated. Otherwise, they wouldn't volunteer for that type of research study to be a participant. They tend to be a very limited and tightly controlled population of all people generally with relatively mild Parkinson's symptoms, and their exercise is paid for. So their gym membership is paid for, their personal trainer is paid for, and maybe they get an iPad to track their walking. It's not really the real world situation that the rest of us are operating in. This study here is a real world study of the Parkinson's Outcome Project. So this is a representative sample of 8,000 people across the country, and actually there's even some international sites. And what you see in the top left pie chart is that people with very early Parkinson's disease in the lighter shades of gray, those people, more than 50% of people with very early newly diagnosed Parkinson's disease are achieving the exercise recommendations. In Hoehn-Yahr stage 2, down in the bottom left, you see it's a more even split with the darker shades of gray indicating people who are not exercising at all or who are low exercise amounts. So they're exercising some, but not achieving the recommended 150 minutes a week. In the top right, you see in Hoehn-Yahr stage 3 Parkinson's, this is when people start to have balance problems, that now you see more darker shades of gray. So more people are having trouble making those exercise recommendations. And by Hoehn-Yahr stage 4 and 5 Parkinson's disease, these are people who might be having more freezing of gait. People with Hoehn-Yahr stage 5 have difficulty getting out of bed without having a caregiver assistance with them. 75% of those people aren't meeting their guidelines. So the number of no and low exercisers increases as the disease severity increases. Next click. However, what we found in this population is that people who did achieve recommended doses of exercise, they had a slower decline in their quality of life and a slower decline in their mobility over 2 years. So what we want to do is try to get more people into that regular exercise group. And one more click. Interestingly, the benefits of exercise on quality of life was the greatest in this bottom right-hand corner in those individuals with Hoehn-Yahr stage 4 and 5. And this is where I think the exercise professional community is so important, because people who have more advanced Parkinson's disease are going to need more physical assistance to exercise, as well as more motivation, because they can have problems with apathy, which is essentially that they have a really hard time getting going. And so having that extra motivation from a family member, from an exercise group, or from a personal trainer or group exercise instructor is really going to be a key ingredient to having them achieve their recommended exercise. Next slide. So if you are lucky enough to be working with an individual in Parkinson's, what should you do? And these are where the guidelines come in. Next slide. What are guidelines? Guidelines, click, are one more click. Guidelines are the public recommendations on exercise prescription for people with Parkinson's disease. So using exercise physiology, exercise professional language, it's the objective knowledge about the frequency, intensity, time, type, volume, and progression of exercise, or fit BP. So the guidelines are giving you that additional knowledge. And one more click. Guidelines are not related to the quality and skill of application of the guidelines. So it's easy to memorize the guidelines, but how do you actually apply them to people with Parkinson's disease is a little bit more tricky. What I'll cover after the guidelines are the competencies, and that the competencies help you understand more how to apply the guidelines. So the guidelines themselves don't ensure the competence of the exercise professional, but an exercise professional who has all the knowledge can then gain the skills and application. Next click. Next slide. So these are the guidelines, and I'm going to go through each one of these types of exercise one by one, because you obviously can't read the little print on this without straining your eyes. But you see on the left-hand side, we have the columns, or each row is the frequency. We combined intensity and progression. We have time and volume. We have the type of exercise, and we have disease-related considerations. So the disease-related considerations are really some of the precautions that you have to keep in mind when working with somebody with Parkinson's that are maybe a little bit different from the general population. And across the top, the 4 exercise domains. This was one of our one of our objective goals was to make sure that you knew that people with Parkinson's should be working in the aerobic domain, in the strength domain, in the balance domain, and we combine agility and multitasking with the balance domain. So BAM, balance, agility, and multitasking, as well as flexibility. And the website here is, if you just kind of Google parkinsons.org exercise guidelines, you can get your own copy of this guideline. Next slide. Also on that website, you will see a copy of the infographic that was made in a collaboration between the Parkinson's Foundation and the American College of Sports Medicine that quickly summarizes these different domains of exercise and what should be done. Lisa Hoffman, who'll be speaking to you later today, will give you the information that you need if you wanted to order a copy of this for your clinic or for your exercise gym. It's just a very nice, concise infographic that can help exercise trainers as well as people with Parkinson's disease. Next slide. So, and you can click 2 or 3 times, 2 more. So the exercise guidelines are adapted from a number of different places and sources of literature. We use the American College of Sports Medicine's guidelines for exercise testing and prescription, which has a chapter on people who have other health conditions. There's also an ACSM, exercise management for persons with chronic diseases and disabilities, that has a chapter for people with Parkinson's disease. There's also a number of other sources of information about exercise for people with Parkinson's disease, including NCPAD, or the National Center for Health and Physical Activity Promotion for people with disabilities, the U.S. Department of Health and Human Services Physical Activity Guidelines for all Americans, as well as physical therapy texts for PT resources. And then in our last slides of this talk, there's some more information about Parkinson-specific research in exercise and PT, the actual studies themselves. Next slide. So I apologize, there's a little image there blocking it. I didn't intend it to be a top secret there, but for aerobic exercise guidelines, the intensity is recommended that people start with moderate intensity exercise, 40 to 60% of their heart rate reserve, or a rate of perceived exertion that's 12 to 13 on a 20-point scale, the 6 to 20 rate of perceived exertion scale, or 3 to 4 out of the 10-point rate of perceived exertion scale. And that individuals would progress to vigorous intensity exercise at 60 to 85% of heart rate reserve. And this exercise progression is a really key component of exercise for people with Parkinson's. A lot of times people are in groups or are doing exercise on their own, and they kind of have been doing the same thing, you know, for the last 2 years, or maybe this is the same exercise routine that they've kind of had for the last 20 years even. But in order to see continued gains with Parkinson's disease, it's important that the exercise progress. We recommend 30-minute bouts of continuous exercise if possible, or it could be intermittent, you know, 10 minutes, 10 minutes, 10 minutes throughout the day. But if we can get people to 30 minutes of moderate aerobic intensity continuous, that's going to confer, we think, greater benefits. That's the way the research studies are generally done, and to build to 150 minutes a week. The type of exercise, or all the different aerobic exercises that you could be doing. It could be walking, it could be running, it could be biking, depending on what is safe for that individual. Some examples include cycling at a high rate of RPM, revolutions per minute, so 80 to 90 RPMs. Could be a high intensity boot camp style class. So there's a lot of different options. Next slide. It is important to consider the Parkinson's safety concerns. So it's important to consider somebody's ambulatory status, or how well they're walking, what type of physical assistance or equipment they need to walk safely. So this nice picture of a woman on a treadmill, they might need a treadmill that has longer armrests, or arm guides, so they can hold on. Because it's, you know, if somebody's holding onto the front of a treadmill, it forces them to lean forward, which actually is bad for people with Parkinson's disease, and might cause them to have worse walking or to trip and fall. So you'd want treadmills that have long arms to extend back. You might also want a safety harness on your treadmill. There's something called body weight support treadmill training that we use in physical therapy, where we actually use a harness that we hold them up with the legs. And that's not normally necessary for people with Parkinson's. They don't normally need to be lifted up when they're walking. They just might want a safety harness on, or you might want a safety harness on them, so that you can step away for a moment without having to worry about their safety on the treadmill. You could use a gait belt if you are able to stand right there with them on the treadmill. You could use a gait belt, which is just a belt around their waist that gives you something to hold on to or grab if you need to. If they're doing aerobic exercise on a treadmill or walking over ground, there's a risk of kind of take a stutter step or stop moving, and that places them at increased risk of falling. Somebody who has freezing of gait should probably I would say, would need to be in a safety harness on a treadmill, or that's how we would treat them in the clinic. There's also a risk that people with Parkinson's disease have what we call autonomic dysfunction. And what this means is that the part of their brain that controls their blood pressure and their heart rate gets affected. Some people have what we call orthostatic hypotension, which is where when they stand up, if they stand up too quickly, their blood pressure drops, and that places them at increased risk of falling, just having a brief fainting episode. So you might want to make sure that as soon as somebody stands up, you're not like off and running. You take a minute to stand up, let the blood settle before you keep walking. And more importantly, for people doing aerobic exercise is the blunted heart rate response to exercise. Exercise professionals think of having a blunted heart rate to exercise as being something that somebody who has high blood pressure who's on a beta blocker medication, their blood pressure doesn't rise the same way and their heart rate doesn't rise because the medication is keeping it under control to keep their blood pressure down. But for people with Parkinson's disease can have this problem even without being on a beta blocker. So if you're trying to use heart rate to say, oh, your heart rate should go up to 125 to show that you're working at moderate intensity, they might have the rate of perceived exertion of working out at moderate or vigorous intensity, but their heart rate might not be in that exercise zone. So that's why it's important to use the rate of perceived exertion scale in addition to monitoring heart rate when individuals with Parkinson's are doing moderate to vigorous intensity aerobic exercise. And then it's also really important to consider any other comorbidities or conditions that a person has that could be musculoskeletal or cardiorespiratory, because those could be impacting their aerobic exercise. So the last thing we want is to help somebody exercise. They do a great job for a week, but then they develop knee pain that's so bad that they have to sit down for the next 2 weeks. So we need to try to balance what they're doing with their risks and any known like arthritis that they might have. Next slide. So moving on to the strength exercise guidelines, the exercise studies that we based our guidelines off all do a 2 to 3 days a week of strengthening exercises, challenging all major muscle groups, non-consecutive days. So very similar to the way that we would be prescribing strengthening exercises in a healthy population. We consider them, because many people with Parkinson's are older adults, we would want to be cautious with our intensity and progression to start a little bit lower, do a higher number of repetitions at a lower weight to make sure that they learn good form so they're not at risk for example, tearing a rotator cuff. That's one of the common problems we hear of people with Parkinson's who start exercising too quickly, particularly if they're in some kind of like boxing class and they're not using good form and they don't have good strength in their shoulders, they're really at risk of injuring themselves. So we want to make sure that they have good form before we start progressing their weight for the intensity of their strengthening activities. But ultimately build to, the studies might be like 2 60-minute or 2 90-minute strengthening sessions a week. And exercise shows that people who do exercise, just strengthening even if we just take off all the other exercise and just use like aerobic as a warm up and cool down, if people who are not previously exercising start going to a gym, a regular old community gym, working with a trainer who has specialized training in Parkinson's disease twice a week for 60 to 90 minutes, that those individuals had gains in function initially over the first 6 months, and then over the next 2 years, those individuals maintained those gains. Whereas people who are doing gentle exercise, the very typical, like, I'm going to stand on one foot and move my leg out to the side and do some sidestepping each way or some lunges. Those individuals also got better when they first started exercising. But over the next 2 years, they kind of went back to where they started. Whereas the people who were exercising really hard got better and maintained that exercise. And what was the key ingredient for maintaining that exercise? It was that key word of progression. They were working with personal trainers, and so the personal trainer could watch them and keep them safe and help really push them to lift more and more weight as they exercise. So those were individuals using progressive machines, body weights, dumbbells, doing eccentric strength training, resistance training with instability. So there's a lot of different options that you can use in the community. Next slide. Special considerations for strengthening exercise include watching individuals' body mechanics and posture, estimate their 1 repetition max safely so you know that you're starting them at a good weight, progress with high repetitions, or progressive in general with high repetitions, time their strength training for when their medications are on for optimal functioning. So people with Parkinson's disease, if their medications, they sometimes work really well for a couple hours and then they get a little bit worse and then they work really well and then they get a little worse. You want them in your gym where things might be a little tight as they navigate around equipment. You want them in your gym when their medications are working. And again, here, consider comorbidities like spinal stenosis, osteoporosis, or osteopenia. Next slide. For balance, agility, and multitasking, again, here, you want to do 2 to 3 times a week of a focused balance, agility, and multitasking workout. But if you can work some balance and agility activities into their daily life, that's going to hopefully be more, that's a better goal. So they're might be working out with a community exercise professional, doing yoga or doing boxing, the sensory motor agility program, Tai Chi. You might do that for 45 minutes or an hour, but then have some other little things that they can work into their routine, like standing on 1 foot while they're brushing their teeth or something, standing on 1 foot during the 2 minutes that you have food in the microwave. Those are all good ways to work some balance into daily routine. Next, and I'm not going to go through all of the different types on that slide, but because most people here, I think, are familiar with them, but I want to make sure that we talk about some of those considerations. And one of the things to consider, again, here is the varied levels of ability related to cognitive engagement and attention, particularly with multitasking. So some individuals, you have to consider different physical abilities and their safety related to fall risk, but also some people with Parkinson's disease can get distracted very easily. So even though they are walking just fine in a wide open level surface, when they then get into the equipment of a busy gym environment and people are talking and dumbbells are clanking, then they might be more inclined to fall or to trip over one of the little, like a foot of a equipment machine sticking out. So you have to make sure that that you're working them at the right level for their cognition and attention and providing the appropriate spotting. They might need upper extremity support. So the image here of somebody doing kind of a yoga move on 1 foot, somebody with Parkinson's might need an adaptation like having a chair or a countertop or a bar that they can hold on to when they're doing their balance activities. They also might have the risk of freezing of gait, should use a gait belt for safety if needed. And again, to consider comorbidities, certain comorbidities like a peripheral neuropathy where they don't have good sensation in their feet would impact their balance as well as their Parkinson's, as well as cognitive decline. Next slide. So the flexibility, moving on to flexibility exercise guidelines. Similar to balance, we recommend 2 to 3 days a week of like a focused flexibility exercise. But again, it would be great if people could just work it into more like of a daily routine of stretching, even if it's just 10 minutes in the morning or in the evening for what we would call static stretching. So in time and volume, you'll see that static stretches should be held for 15 to 60 seconds, 2 to 4 repetitions each stretch. It really depends on whether you're trying, how long to hold the stretch really depends on if you're just trying to maintain their flexibility and you're using your stretching as a warm up or a cool down, or if they have some serious muscle tightness in their calf, then they should do calf stretches for a longer duration, hold them longer, do them more frequently. We recommend dynamic stretching, like 8 to 10 movements in each direction as a warm up or cool down activity. So this would be like your neck circles or arm circles to help warm up. And then include diaphragmatic breathing or meditation. That can be incorporated into flexibility. It frequently is in the research studies. And some other examples include yoga, that includes some flexibility and some balance components. And that's really where the competencies come into play, because there's so many exercises that can address 2 birds with 1 stone. And that's really important because if you've been adding these up over the course of this talk and you're thinking 150 minutes of aerobic exercise plus 2 to 3 times a week of strength exercises plus 2 to 3 times a week of balance plus 2 to 3 times a week of flexibility, we've run out of days in the week. So it's going to be really important that a skilled community exercise professional can help the person with Parkinson's kind of figure out how they can plan their exercise routines to maximize their guideline adherence while also leaving enough time in the day to go do all the other fun things like going out to lunch and, doing the other daily life things. Next slide. The flexibility related considerations are just to consider that some people with Parkinson's disease have something called dystonia, which could be just tonic. That means that they have a tightness, like a muscle spasm that just is tight or tonic in a limb. It frequently happens in their ankle muscles where their ankle kind of turns in, or in a hip where their hip turns in. This can be very painful, and it's very important to kind of stretch those muscles to the best of our ability. For some individuals, these dystonias kick in activity induced is what I'll call it. So they normally walk fine, but after they walk for a long period of time, they'll start getting their foot turning in. So it would be something to just watch out for. And they should let their doctors know if you observe it in your exercise sessions. You want to make sure that they tell their doctor about it. People with Parkinson's have that they can get a worsening of their flexed posture that gets worse as the disease progresses. And so doing exercises to promote upper trunk extension, as well as hip extension, can be very important. And again, to consider comorbidities like osteoporosis or osteopenia, which you wouldn't want to do a lot of like forward flexed bending if somebody has bone mineral density loss in their spine. Pain and dystonia are things to consider. And so the final special consideration, next slide, is just to consider that the individual, the personal trainer, the exercise professional in the community, and the person with Parkinson's disease should consider collaborating as a team with a physical therapist who specializes in Parkinson's disease, because where the physical therapist comes into play is that they know Parkinson's disease, but it's also a part of their license to really take into account an entire complex medical history, everything else that's going on with the patient, so that if there are special considerations, that exercise professional can kind of bounce ideas off of the physical therapist to make sure that they're doing things safely. Next slide. So the competency section here is now, how do we apply all of that knowledge safely in the community? And I'm going to give you the by the books, how do you apply it, and tell you a little bit about the competencies, which are now online, before Jenny hopefully gives you some more practical details. She gets all the fun for her presentation. The next slide. These competencies present the curriculum requirements for the knowledge, skills, abilities, and other attributes for entry-level competence as a Parkinson's exercise professional. And our goal of the competencies we have several goals, but a lot of times it's not necessarily for you as the individual to have a curriculum that you have a self-study, but it would really be for the programs that create exercise education for health professionals to use the information and the competencies to make sure that they're teaching people who are exercise professionals all of the right things that they should know. So then somebody with Parkinson's can go to an exercise professional who went to one of those training courses and know that they have a good body of knowledge. Next click. And can you click 4 more times? So the goals for these competencies are to reduce the unwanted variation in community-based exercise delivery, to add Parkinson-specific information to existing competencies for exercise professionals. For example, I mentioned that there was ACSM and ACE have competencies for exercise professionals, but we wanted to state what Parkinson-specific information was needed. We want to improve the consistency of education provided to Parkinson's exercise professionals in those community classes. We want to enable the recognition of qualified exercise education providers. So exercise education providers being the companies out there that provide continuing education courses for exercise professionals. And we want to increase the number of well-trained personal trainers and group exercise instructors in our communities to expand safe and effective exercise opportunities for people with Parkinson's. Next slide. The competencies define the appropriate prerequisites and scopes of practice. So I mentioned earlier that the appropriate prerequisite that we are really hoping is that people who are exercise coaches, group exercise instructors, or personal trainers should have a prerequisite of having a certification as a certified personal trainer or certified group exercise instructor through ACSM, ACE, or one of the other exercise credentialing organizations. They there's education for the providers, and the components were written with 2 steps. Like, providers classes should include these criteria, and exercise professionals should know these things. And so you could go down as an exercise professional and check off the list of what, and kind of say, like, do I know these things? And if I don't know these things, where am I going to learn that information? And we drafted the competencies with 5 domains. The first domain is Parkinson's diagnosis, treatment, and disease-specific role of exercise. So if I was using terms in some of my earlier talks, like freezing of gait or autonomic dysfunction or orthostatic hypotension, the competencies would state that you can learn all those things in one of these credentialed exercise classes. The second domain are what are the pre-screening activities that a community exercise professional should do when they're working with somebody with Parkinson's disease. So what's the information that they should screen for above and beyond the standard healthy population? They would talk about individual and group exercise design for people with Parkinson's disease. So I mentioned some safety considerations, like how close or far apart your equipment is, how close or far apart people are, having bars or something that they could hold on to. Those are some key components of exercise design. They also include a domain of exercise leadership for people with Parkinson's disease, and this includes behavioral change strategies and counseling that one might need to do when working with somebody who has a chronic degenerative health condition. And finally, the last domain is interprofessional communication and program development. Next slide. And you can click one more time. So what we are hoping is that in this motivation image here, that the exercise professional who's working with that person with Parkinson's disease was taught and is adhering to guidelines and competencies. So we know that they're pulling this person ahead, but they're pulling them ahead safely and effectively. Next slide. And this qualified exercise instructor, and we'll do one more click, is really that merging that credentialed exercise provider, so they know exercise, but now they also add Parkinson's specific exercise to their knowledge. Next click. And so the credentialed exercise instructor, we recommend any of the different NCCA accredited certification programs. So they're listed here, and the link on this slide, if you are not a credentialed exercise instructor, goes to a number of different credentialing bodies that credential different types of exercise instructors. And if you're a person with Parkinson's and you are looking for a credentialed exercise instructor, there is the United States Registry for Exercise Professionals, which gives a list of people who have credentials. Next click. And soon we will have an accreditation process where, one more click, where you can find people who are educated by a Parkinson specific exercise education provider. And Lisa Hoffman will talk a little bit more about that later today. Next slide. I just want to thank you all very much for your attention, and I will kind of work with Katrina here to answer some of the questions, and we'll go down one more slide. In the slide deck, you'll see a list of all of the references for the research related to the different types of exercise, aerobic, strengthening, balance, and flexibility. If you would like more information on those resources, I recommend reviewing this literature, but hopefully that's where the exercise guidelines and the infographics that have been created are a nice summary for you that'll be a little bit easier to read than the articles themselves. So thank you again for your time, and I'll pass it off to Katrina.
Okay, awesome. Oh, great. Thank you so much, Miriam. There was a lot in your presentation, a lot of great information. Thank you so much for being here today. Some of the questions we've received, I think, really tee up for Jenny. We received a few questions about what specifically should I be doing and what do some of the specifics mean in these recommendations. Let me go ahead and ask you a couple of the questions that came through. One that came through was, are these recommendations long-term goals? The person who asked this question said, I can see this being pretty overwhelming for a person with Parkinson's, especially if they're not yet an avid exerciser. Any idea, any goal?
Absolutely. Long-term goal is a great way to put it. And that's exactly what I like to think of with the physical therapist helping the community exercise professional to figure out the prescription and what are the short-term goals and what are the long-term goals, what's realistic and what's safe for an individual. Nobody who is a non-exerciser should start at the top. You're always kind of starting at the beginning, working your way up, whether it's just doing let's just try to get somebody outdoors walking, taking a community walk. Then once they're walking 20 minutes a day, then it would be, let's have them monitor their heart rate or their rate of perceived exertion to try to get into the moderate intensity zone. And I would never want to discourage somebody to say, but I'm not working out at a vigorous exercise zone, so I'm not doing it. I'm not meeting recommendations, because we all know as exercise professionals that some is better than none. And that's really where the competencies come in. It's how to apply this information for an individual using the appropriate behavioral strategies for goal setting and action planning to help somebody go from nothing to something. Or if somebody already is a great exerciser, how do we monitor them to pick up on when things are starting to drift off? It might be that they drift off of exercise every winter. I know that that is something that happens. I'm presenting here from Chicago. That's something that happens regularly. So how do we monitor for those declines in exercise and give them boosts when they need them? And that's the competency, that's the skill and ability of applying the exercise, as opposed to just having the knowledge of what to do.
Great. And again, I think Jenny's going to talk a little bit about that. One of the things I also appreciated you saying in the presentation was that, the reminder that a lot of activities hit two birds with one stone, right? An activity that it could be in the aerobic category could also be helping with strength, balance, what have you. So that was also
Yes, and oh yeah, so I was gonna say, I do hope, I'm assuming that Jenny will cover that really well, because I know that one of the programs that was developed at Oregon Health and Sciences University was the Sensory Motor Agility Boot Camp type program. And that's a perfect example of a program that is really focusing on agility and balance, but is encouraging people and monitoring their aerobic intensity as they're doing that program. And so that's one example. There's a number of community exercise examples that do similar work. Some of the other examples are Parkinson's Wellness Recovery or Rock Steady Boxing. These are all things that people with Parkinson's could consider that would address both aerobic and balance and agility at the same time. They also all include a warm-up of flexibility exercises. So all of these group classes will be covering flexibility, probably with aerobic and balance. So your 90-minute class or your 45-minute group class is probably hitting many things at once.
Great. So we also got a question about, why are the recommendations for aerobic activity 30 minutes 3 times a week as opposed to just 150 minutes over a week?
That's a great question. And we decided to be a little bit more specific. Right now, the physical activity guidelines for all Americans are 150 minutes over the course of a week, with any type of breakup. It could be 5 minutes at a time, 10 minutes at a time, 30 minutes at a time. However, the research studies in people with Parkinson's disease mostly focus on aerobic exercise that's delivered in longer bouts. So in particular, with the vigorous exercise intensity, people were asked to walk on a treadmill for 45 minutes 4 times a week, hoping that they'd actually do 3 times a week. If you ask, something always comes up and you have to cancel a session. But all of those were those longer stretches where there's a warm up, a period of moderate to vigorous intensity aerobic, and then a cool down. And this is kind of the difference between physical activity and exercise. So the physical activity guidelines are recommending 150 minutes of moderate intensity physical activity. And we are hoping that people are really doing that with a focused exercise. And exercise, the differentiation is that exercise is physical activity that's being done more intensely with the exact, the thought in your mind that you're doing it to improve your health or fitness. Whereas physical activity, could be your daily commute, it could be walking the dog. Some dogs are a more intense walk than other dogs. So you really have to think about your intensity and put that focus, get your mindset on, I'm trying to do this to get stronger, to improve my aerobic intensity.
Thank you for that clarification. She also asked, what is considered high repetition to muscle fatigue? Is it?
Yes. So generally speaking, with older adults, a lot of times they are doing higher number of repetitions. So by higher, I mean 10 to 15 repetitions. And we would say to muscle fatigue. The Parkinson's exercise strength training study, that is kind of the seminal work on progressive resistance exercise in Parkinson's disease, they are generally actually doing 8 to 10 repetitions. In healthy young adults, you might even see 6 to 8 repetitions of to fatigue, but they're using a higher load, 6 to 8 repetitions. In a supervised setting of somebody with Parkinson's disease, you could maybe do 8 to 10, but the guidelines were a little bit more conservative based on the ACSM's exercise guidelines and kind of for older adults in general who might have osteoporosis or osteopenia. You might lower your load and do a higher number of repetitions. I would say 10 to 15, but you want to achieve that fatigue within that 10 to 15. So
Okay.
yes, simple answer to that question would have been yes to fatigue, but I wouldn't. What happens in PT clinics, and this is me as a PT critiquing myself, so I feel like I can do it. Is a lot of times we'll say like, oh, 3 sets of 10, but we aren't pushing people very hard, so they could just do 30. And if somebody can do 30 of something and not get to the point of fatigue, then we aren't working them hard enough. And so in the community, both physical therapists who are working with patients one-on-one, as well as exercise professionals, know when that fatigue occurs and make sure you're pushing them to that point.
Yeah, I think that's a recurring theme when we do our trainings with Jenny is you really have to push people. So
Yeah.
that's one of the great things about having exercise instructors and community exercise programs. And so just to wrap up, Miriam, I'm just wondering, as you were going through this work, knowing that you have a background as a researcher, as a physical therapist, was there any one big key takeaway or any surprise you had as you were going through creating these recommendations?
I think not a lot of surprises, but I think we were really challenged as a group to come up with recommendations and to decide how to give our recommendations in a way that would be effective and safe for somebody who's newly diagnosed, so that Hone and Yar stage 1, it's barely noticeable that they have Parkinson's. And maybe they've been an exerciser their whole life. And so these are the people who are coming in to PT or to exercise saying, I'm already an exerciser. I just want to exercise perfectly for my Parkinson's disease. But also for those people who have Hone and Yar stage 4 and 5 Parkinson's disease who really need help, who want to work with an exercise professional because that's going to be the only safe way for them to engage in community exercise, but they're going to need more one-on-one spotting or somebody to use a gait belt to hold on to them. So how do we create these guidelines that are going to work for everyone? And I think the surprise was really how challenging it was for us to try to come up with something. So I would say that these guidelines are very easy to apply to somebody with very early Parkinson's disease. And most
Yeah,
people with very early Parkinson's disease, I would treat like I would treat, any healthy person, in many ways. But I would be focusing more on that balance, agility, and multitasking part than my general 50-year-old who I would work a little bit on balance, but might be focusing more on aerobic strength training. But with Parkinson's disease, I'd say, let's start doing this stuff now to nip any problems in the and then for honing our stage 4 and 5, you're looking across the board and it's like, well, how can I get them doing any of these exercises?
yeah. Yeah, kudos to you and to the Parkinson's Foundation for bringing this all together to create these recommendations, because it is another thing we hear a lot when we do our trainings is what do you do across the lens of stages, and how do you support people throughout the whole journey of Parkinson's? So I do appreciate you being here with us today, Miriam. Thank you so much. We are going to go ahead and take a 10-minute break now. So it is 9:50 Pacific time, 12:50 Eastern time. We will be coming back at 10 a.m. Pacific time, 1 o'clock Eastern time to hear from Jenny, who is going to talk about how you incorporate these recommendations into an exercise program, get a little bit more into the detail of the application of the recommendations. So with that, Miriam, I can't thank you enough for being here. Thank you so much for that presentation. We are really grateful to you and the work that you've done. So we will say goodbye now.
Thanks, you're welcome. And looking forward to Jenny's talk. Thank you all.
Yeah, take care. Thank you.